yes, I will present data from a study on improving the performance of cholera diagnostic tests. Cholera outbreaks are caused by a bacteria called Vibrio cholerae, and there are two serogroups that are responsible for outbreaks, but serogroup O1 is currently the only cause of outbreak throughout the world, with O139 limited to the Asian continent. Outbreak confirmation relies on the identification of the bacteria by culture or PCR, but outbreaks often occur in areas where laboratory capacity is limited, and in this context, a rapid diagnostic tool for the diagnosis of cholera would be a useful tool to quickly identify the cholera cases and start an alert in order to speed up outbreak confirmation and response. Several rapid diagnostic tests are commercially available, but none is currently recommended by MSF. All these rapid tests are immunochromatographic assays in dipstick or cassette format, and most of them detect both serogroups O1 and O139 on the same test. But only few have undergone large independent field evaluations. And manufacturing practice of the companies producing some of these tests have shown weaknesses in assessments done by WHO and MSF. A laboratory evaluation sponsored by WHO was performed at the Institute of Tropical Medicine in Antwerp, in Belgium. And 9 tests from 4 different manufacturers were evaluated on purified LPS and bacterial cultures. This evaluation revealed that most of these tests had some issues and suggested that SD Bioline and Crystal VC had slightly higher analytical sensitivity than other tests. Crystal VC is the rapid test that has been mostly used and evaluated recently. And it has consistently shown high sensitivity but limited specificity. In 2009, MSF recommended its use for outbreak detection using an algorithm of at least 3 positive tests out of 10. In 2011, several changes were made to the test, including a switch between the O1 and O139 line. Since then, several false positive results false positive O139 results were reported from the field, and the test was eventually removed from the MSF catalog. The product insert of the test actually recommends 2 different types of uses for Crystal VC. The screening test is done directly on the stool after a small step of dilution in a sample diluent buffer. And it's the method that has been mostly used and evaluated recently. The confirmatory test, or which I will call also the enriched test, includes a step of bacterial growth in alkaline peptone water for 4 hours at ambient temperature. And the early data on the test prototype suggested that it highly improves the specificity of the test, which would solve most of the problems encountered with the direct Crystal VC. However, it had not been extensively evaluated in the field. So in the absence of any recommended rapid tests for cholera, we wanted to evaluate the performance of the enriched method for Crystal VC. We also evaluated the direct test and culture using PCR as the reference standard. This was a sub-study of the vaccine effectiveness study in Juba that Francisco just presented. For all individuals aged more than 1 year presenting with acute watery diarrhea during the study period, a stool sample was collected. The rapid test was performed both directly on the stool and after enrichment in alkaline peptone water for 4 to 6 hours. Culture was performed at the Juba National Laboratory and at Institut Pasteur in Paris from wet filter paper. PCR was performed from wet filter paper at Institut Pasteur and from dry filter paper at Johns Hopkins University. 104 cholera suspected cases were included in the study. The direct test was positive with the O1 line only in 18 patients, positive for O1 and O139 lines in 31, and positive with the O139 line only in 7 patients. And on the right, you can see a picture of a test that was positive both for O1 and O139. The enriched rapid test was positive for O1 only in 32 patients and did not show any positive O139 line. 38 cases were confirmed positive for Vibrio cholerae O1 by PCR at Institut Pasteur and none for O139. As reported previously, the sensitivity of the direct tests was very high. And when considering only the O1 line as positive, the specificity was 80%. And it dropped to 69% when we considered also the O139 line as positive, as might be the case by insufficiently trained users. The enriched RDT had a very high specificity with a slightly lower sensitivity. And these performances were similar to the performance of culture at the National Laboratory in Juba, and higher for the sensitivity than the culture at Institut Pasteur, which is probably due to the long delay between of an average of 2 months between sample collection in the field and sample testing at Pasteur due to the shipment constraints. So these results confirm the limited specificity of the direct test and the high sensitivity of this test, and documents for the first time the high level of O139 false positive results. The enriched test had lower sensitivity but a very good specificity, which made this assay as reliable as culture in this context. One of the limitations was that the direct test was done directly on the stool without using the sample diluent buffer as recommended by the manufacturer. And one other main limitation was the low sample size, since the study was done when the outbreak was declining. So if these results are confirmed in other settings and are in larger sample sizes, the enriched method could be a good alternative to culture where laboratory capacity is limited. And although the additional step is very simple, it means that the test is not so rapid anymore, and that it requires supervision in order to ensure that the enrichment is not skipped. Culture currently remains the gold standard for outbreak declaration and will remain needed for the characterization of outbreak strains. More field data is coming from other field studies. So in Malawi, we've been also using the enriched crystal VC, and we will be able to compare the results to results of PCR. And in Zambia, in Lusaka, the other promising rapid test, SD Bioline, was used in parallel with culture, and preliminary data suggests that the performance of even the direct SD Bioline test might be quite good, but we are waiting for the results of PCR for a good comparison. Head-to-head diagnostic evaluation on a larger sample size will be conducted, and this will include a new version of the Crystal VC that's focusing on O1 only, and a simplified version of SD Bioline. This, together with the possible inclusion of cholera in the WHO diagnostics pre-qualification process, will hopefully lead to the identification of the best reliable, simple, and rapid assay for cholera outbreak assessment. And I would like to thank all the people who actually did the work in the field. And thank you.